Assalamualaikum doctors. In this video I am discussing a video station that is ophthalmia neonatorum or neonatal conjunctivitis. So look the baby, newborn baby, that is how it's present. So description is like that. I can see a baby in a hospital setting sleeping on his mother's legs, calm, not irritable, appears well, not in distress, with no obvious any dysmorphic features. I can see yellow discharge coming from both his eyes with swelling of his eyelids. The eyes not open. I cannot see if there is any redness is there. So it is yellow discharge coming from both his eyes with swelling of his eyelids. The eyes not open. I cannot know if there is any redness is there. What are the causes of neonatal conjunctivitis or ophthalmia neonatorum? Bacterial causes are Chlamydia trachomatis, Neisseria gonorrhea, Staphylococcus aureus, Streptococcus pneumonia, beta hemolytic streptococci in Haemophilus influenza, Moraxella catarrhalis, E. coli, Pseudomonas species. So mainly we remember the bacterial cause are Chlamydia trachomatis, Neisseria gonorrhea, Staphylococcus aureus. These are. Viruses are herpes simplex, adenovirus. Others are blocked nasolacrimal duct and detergent. Differential diagnosis. Either according to bacterial, viral or others we tell. Then sticky eye with blocked tear duct in which there is no inflammation of the conjunctiva. Congenital glaucoma in which there is corneal opacity. Swelling of the conjunctiva and eyelids as part of preseptal or orbital cellulitis. So first of all, according to age neonate, so ophthalmia neonatal we tell that the cause according to we tell the cause like bacterial cause, maybe it caused by Chlamydia trachomatis, caused by Neisseria gonorrhea, Staphylococcus aureus. Viral cause like herpes simplex, adenovirus, other any blocked nasolacrimal duct, and other you can say like congenital glaucoma. There is corneal opacity, but it is not present. Swelling of the conjunctiva and eyelid is a part of preseptal or orbital cellulitis. What history will ask in ophthalmia neonatorum? First, the onset of these conditions. Very important to suspect the causative organism. So onset is very important. Course and duration of the illness. Is it yellow or purulent, viscid, sticky, itchy, amount of the discharge? Any redness is there? Can he open his eyes? Excessive tears? Any eyelid swelling? Are there any vesicles in the face or mouth or skin? Is it preceded by trauma or operation? Associated with fever, affection of his sleep or activity? What about if the child is crying, irritable or in pain? Any abnormal movement or seizure? Are there any coughing or chest symptoms? How many feeds he is taken per day? Number of the diapers change. Ask about the mother if she has any sexually transmitted disease. Mode of delivery, vaginal is important. Again, the history we ask in ophthalmia neonatorum. First of all, the onset of these conditions, course and duration of this illness. Number one, the secretion. Is it yellow or purulent, viscid, sticky, itchy, amount of the discharge? Any redness is there? Can be open his eye, excessive tears, any eyelid swelling? Are there any vesicles in his face or mouth or skin? Is it preceded by any trauma or operations? Associated with fever, affection of his sleep or activity? What about if the child is crying, irritable or in pain? Any abnormal movement of seizures? Are there any coughing or chest symptoms? How many feeds he is taken per day? Number of diapers change. Ask about the mother if she has any sexually transmitted disease. Mode of delivery, vaginal is important. Now what examination we do in ophthalmia neonatorum? First of all, I will assess the baby carefully. ABC, airway breathing circulations, vitals, hydration status including enterofontanelle, capillary refill time, skin turgor and amount of urine in the diaper. General examination for any vesicles. Eye examinations. Chest examination for pneumonia and neurological examinations. So examination are I will assess the child carefully, baby, ABC, vitals, hydration status including enterofontanelle, capillary refill time, skin turgor and amount of urine in the diaper. General examination for any vesicles, eye examination, chest examination for pneumonia and neurological examination. Investigation are swab for all like gram stain and bacterial culture and sensitivities. An AAT test if high risks and bacterial swab for gonococcus and HIV antibody, HBsAg and HCV antibody from mother or baby. So swab we can take in viral PCR, NAAT test and if any HBsAg, HCV antibody, if any high risk. Management, I will involve my senior or consultant, pediatrician, ophthalmologist if needed. 4 to 6 hour eye toilet using sodium chloride 0.9%. The cooled boiled tap water acceptable for home use. So sodium chloride 0.9% eye toileting we are doing 4 to 6 hour and involve my senior consultant, pediatrician, ophthalmologist if needed. Treat both eyes equally. Frequent eye toilet is necessary. Chloramphenicol 0.5% eye drop Fusidic acid 1% eye drop for Staphylococcus. So chloramphenicol 0.5% eye drop. Fusidic acid 1% eye drop for Staphylococcus. Presentation less than or equal 24 hours of birth suggests gonococcal infections. If herpes is suspected, admit the baby and begin the treatment with acyclovir IV and acyclovir eye ointment while awaiting the result, and up to 14 days. So we are giving herpes, we give acyclovir IV or acyclovir eye ointment. Normally chloramphenicol 0.5% eye drops we are giving, eye toileting, and fusidic acid 1% eye drop for Staphylococcus aureus. Now up to 14 days. Neisseria gonorrhea if suspected, request the urgent gram stain and culture. Assessed by baby for sepsis, swab for PCR. If confirmed, single dose of ceftriaxone 25 to 50 mg per kg IV, maximum 250 mg. Or if hyperbilirubinemia or premature, baby give cefotaxime 100 mg per kg IV, refer to ophthalmology. Chlamydia we are giving azithromycin 20 mg per kg IV single dose or azithromycin eye drop twice daily for 3 days. If maternal chlamydia, if treated successfully in pregnancy, the baby does not require prophylactic treatment. Gonococcal or chlamydia infection detected, then refer the mother and partner to the genitourinary medicine for immediate treatment. Follow-up, review daily either as an inpatient by on-call ophthalmology team or if outpatient via eye causality until clear improvement established. Then refer by telephone to a member of the pediatric ophthalmology team to the pediatric ophthalmology clinic for 5 to 7 days review. Complications are eye irritation or corneal ulceration up to blindness, systemic infections with sepsis and meningitis, orbital and pre-orbital cellulitis and pneumonia. So remember, duration is very important. Which organism is responsible? Neisseria gonorrhea is 0 to 5 days, 5 to 15 weeks chlamydia trachomatis, okay, and 5 weeks to 5 years Haemophilus influenza streptococcus. So remember, 0 to 5 days Neisseria gonorrhea, okay, and 5 days to 5 weeks chlamydia trachomatis, and 5 weeks to 5 years Haemophilus influenza streptococcus. First, we will eye toileting by 0.9% sodium chloride, chloramphenicol 5% eye drop, and fusidic acid 1% eye ointment. Then according to 0 to 5 days, it is Neisseria gonorrhea we think, then we are giving single dose of ceftriaxone 25 to 50 mg per kg IV. But if the child has hyperbilirubinemia or premature, we give cefotaxime 100 mg per kg. Now duration about 5 days to 5 weeks, it is chlamydia trachomatis. Chlamydia trachomatis we give azithromycin 20 mg per kg IV single dose and azithromycin eye drop twice daily for 3 days. And if it is chlamydia infection for gonococcal or chlamydia, refer the mother or partner genitourinary medicine for immediate treatment. And we will follow up either on-call ophthalmology, outpatient, these are. So this is all about ophthalmia neonatorum or neonatal conjunctivitis video station. Thank you.